Hi guys, this is Lab 16 review on the celiac trunk, stomach, liver, and gallbladder. Just a quick word. Hopefully you're not stressing too much about the exam. You're fully capable of doing well. And best always treat this game. You've taken tons of exams before, so we'll just get through it. But good luck, guys. All right, so just a quick review. We have the peritoneum from previous labs, which was a single layer of squamous epithelium, aka called mesothelium, which forms a serous membrane that covers most of the digestive and reproductive organs. It covers the wall of the abdominal and pelvic cavity. We had the mesentery is our basic double-layered version of the peritoneum, specifically for coming from the body wall to surrounds the organs, and we know, of course, when it's along the wall, then it's called the parietal peritoneum, and then along the organs, it's a visceral peritoneum. But the double-walled, double-layered version of this peritoneum, when it goes from body wall to organ, is our mesentery, and then we have really two versions of that. We have omentum, which is from organ to organ, and really we talked about the greater omentum and the lesser omentum, and then we have ligament, which ligament is just a form, omentum is a form of mesentery, and ligament is just a description for a part of omentum or mesentery. All right, then we had the organs of the abdomen. In particular, today we're focused on our front of the stomach, the liver, and the gallbladder. And in relation to our peritoneum, we have our retroperitoneal and intraperitoneal organs. Remember, we have SAD pucker for our retroperitoneal organs. These are the organs that are only partially covered by the peritoneum. And for us today, we don't really have to be too concerned about retroperitoneal or esophagus. We'll talk about it a little bit, but for the most part, our stomach and the kidney and gallbladder are intraperitoneal. All right, so then we had the lesser sac and greater sac, which are formed by the peritoneum that define the peritoneal cavity. The lesser sac we know is bounded behind the stomach, and we have a gap between them, the epilobic foramen. All right, so starting with the stomach, can you name the parts of the stomach? Well, we start off with the part adjacent to the esophagus, the cardia, which connects to the esophagus. We have the cardial notch. Then we have the fundus, which is right at the top. It fills with gas and it contacts the diaphragm. We have the main region, which is the body. It's the largest region. It has lots of glands, our gastric glands. We have our curvature of the stomach. Then we have our pyloric region right here with the pyloric antrum and the pyloric canal. And we have the pyloric sphincter here, which connects the pyloric canal to the duodenum. Right here is the lesser curvature of the stomach, and then we have the angular incisure, aka notch, which defines the boundary between the body of the stomach and the pylorus. All right. Also, we have, of course, we've gotten this in a couple different lectures, but our three layers of the muscle. We have the internal oblique layer, we have the middle circular layer, and then we have our longitudinal layer of muscle, all smooth muscle. Finally, we have our friend the pyloric valve right here in the first part of the duodenum, and then at the top of the stomach, we have our esophagogastric junction, aka this lower esophageal sphincter, and we have two ligaments here that support this region. The first is the phrenoesophageal ligament, so think diaphragm, esophagus. And then we have the phrenoesophageal ligament descending, which is on the other side, so ascending on the top, descending on the bottom, and they're both supporting the esophagus as it goes from thoracic cavity to abdominal cavity. All right, moving on. So we have the anatomy of the omentum. So we said omentum is really just mesentery, which is double-layered peritoneum. But specifically, omentum is mesentery that's connecting from organ to organ. So for the stomach, we have the lesser omentum connecting the lesser curvature of the stomach to the liver. And then it has two ligaments, and we said that ligaments in regard to peritoneum are just specific parts of omentum or mesentery. And so we have the hepatogastric ligament right here, and then we have the hepatoduodenal ligament. And the hepatoduodenal ligament we can see is on the first part of the duodenum and the pyloric sphincter, or end of the pyloric canal, and going to the liver. But specifically, this guy is going to contain a lot of stuff we're going to be looking at today, which is it has the hepatic portal vein, the hepatic duct, cystic duct, bile duct, proper hepatic artery, right and left hepatic artery, or cystic arteries, and we're going to go over all this in just a second. All right, so what structures are found in this hepatoduodenal ligament in the lesser that makes up the lesser omentum? And they are starting with the hepatic portal vein. So we have hepatic portal vein right here. And you can see that branches into the left hepatic vein and the right hepatic vein going into the liver. Then we have the hepatic duct, which you can see right here, our left and right hepatic duct coming in and coming our common hepatic duct, which you can see is draining into our common bile duct with the cystic duct overall. So hepatic ducts left and right with the cystic duct will drain into the common bile duct, which you see right here. All right, then we have the proper hepatic artery, which we can see right here, which is coming from the common hepatic artery right here. And the common hepatic, or the proper hepatic artery is going to split into the left hepatic artery and the right hepatic artery overall. And then finally, the right hepatic artery, which you can see right here, is going to split and give us the cystic artery, which is going to go to our gallbladder. Okay, so this is just, we've cut out a portion of the hepatoduodenal ligament to show that we indeed have these things inside of it, our hepatic portal vein, and then we have our hepatic duct right here, it's called common hepatic duct, and then we have our cystic duct coming from the gallbladder. Those together are draining to our common bile duct, and then we can see that we have the duodenum right there. All right, so what organs are related posteriorly to the stomach? Well, we can already see our friend the pancreas here, but we have a nice list. We have pancreas, left kidney, left adrenal gland on top of that kidney. We have the diaphragms back there. I suppose that's theoretically true, yeah. It's kind of a weird way of writing it, though. That's my bad. Wrote this a couple days ago. Then we have the celiac artery, splenic artery and vein are back here as well, basically below the peritoneum. Terminal part of the superior mesenteric artery and vein, which we'll get to later. We have the spleen, and then part of the transverse colon, which you can see right here overall. All right, can you identify the peritoneal attachment between the organs in this diagram? So we have the greater omentum right here. That's been cut in green. Then we have below the stomach, we have the lesser sac. We have the transverse mesocolon mesentery that's connecting the transverse colon to the pancreas, and then it should be attached to the abdominal wall as well. And then let's see what else. We have a couple of ligaments. We have the gastrosplenic ligament right here, and then so along here, and then the gastrophrenic ligament right here between the stomach and the diaphragm. Okay, not too bad. And then just a couple of things here. Mentioning these retroperitoneal organs, we have our left suprarenal gland on top of the kidney. We have our from the spleen right here, and then we have the splenic artery going to the spleen overall from our celiac trunk, which we can see right here. And we'll get more into that a bit later. All right, so arteries to the stomach, we have the descending aorta, which we're very familiar with. That's going to give a branch, which is the celiac trunk. The celiac trunk is going to branch into three main branches: the left gastric artery, the splenic artery, and the common hepatic artery. Each of those is going to give off branches as well. And so you can see this diagram right here, but I think perhaps it's easiest to just start by, we'll go over them one at a time. All three of these are going to supply blood to the stomach at some point. The left gastric artery, this guy right here, is supplying the left half of the curvature of the stomach. It gives rise to the descending esophageal branch, which anastomoses with the right thoracic esophageal arteries and supplies the cardiac region of the stomach, and then it also anastomoses with the right gastric in the lesser omentum. All right, so the left gastric, which we can see right here, it is a branch off of the celiac trunk, and you can see that it is in fact supplying the lesser curvature of the stomach, and it is giving off an esophageal branch right here. And then it will anastomose with the right gastric artery, which is going to come from the proper hepatic. All right, so that's this branch. Then we have the splenic artery, which is the artery to the spleens, pancreas, and then the fundus of the stomach. It's going to give off short gastric arteries, and then gives off a single left gastro-omental artery, so stomach and omentum. And then it supplies the left half of the greater curvature of the stomach, and then anastomoses with the right gastro-omental artery. And so the second branch, the splenic branch we can see here. So again, here's our celiac trunk coming off of the descending aorta. We can see the splenic branch is posterior to the stomach, and it gives off these short little branches right here, which are labeled with 5, and these are our left gastric, or not left gastric, excuse me, short gastric. Then it's going to descend as the left gastroepiloic, but it's also called the left gastro-omental artery, so it's also called left gastro-omental, and then that's going to anastomize with the right gastroepiloic or right gastro-omental artery. Okay, so you can see that up here as well. So we have the splenic artery, and then it's going to end and give off our short gastrics, and then it has a branch coming down here, which is going along the greater curvature of the stomach, which is our right gastroepiloic artery, aka right gastro or left gastro-omental, left gastroepiloic, and anastomoses with the right gastroepiloic. All right, and then we have a splenic artery coming down as well. All right, then we have our third branch is the common hepatic branch from the celiac trunk. That's going to break off into two main branches, the proper hepatic and then the gastroduodenal. The proper hepatic is going to give us our right gastric, which goes along the lesser curvature, and then that anastomoses with the left gastric, which we saw earlier. Our gastroduodenal branch is going to branch itself into two branches, the right gastromental, which we saw already, and then the superior pancreatic duodenal. So let's just take a look. We have our, right here, the common hepatic artery coming out. We see that it's splitting into, so it's labeled right here. That's splitting into the proper hepatic right here, and that's going to give rise to the left hepatic and the right hepatic, and then you also have that giving rise to the right gastric right here. Then we have the gastroduodenal, which we can see right here, branching from the common hepatic. The gastroduodenal right here is going to travel along and split into the right gastroepiloic, right gastro-omental, and split into as well into the superior pancreatic duodenal artery. All right, so that's probably as clear as mud, but I think the main point is we have our descending aorta, we have the celiac trunk coming off that. That's going to give rise to three branches: the splenic artery branch, the left gastric artery, and the common hepatic. Each of these three is going to give branches that supply the blood, or supply the stomach with blood, and the associated organs that are nearby, aka the spleen, the pancreas, and the liver. Okay, so moving on, how does the esophagus get its blood? Well, that has to do with the left gastric artery from the celiac trunk. So the left gastric, which we can see here, one of the main three branches from the celiac trunk, is going to come off. It splits and gives rise to the ascending esophageal artery, which is going to anastomose with thoracic esophageal arteries. It's going to supply the cardiac region of the stomach, and you also have an anastomose with the right gastric in the lesser omentum, which is the left gastric itself will do that. All right, so just looking back at the left gastric, we have, so right here, left gastric coming down, and you can see the left gastric is continuing. It's going to anastomose with the right gastric right here, and then it's giving off a branch to the esophagus overall, so not too bad. All right, moving on. So can you interpret an arteriogram of the celiac trunk, celiac artery? And that is a great question. So hopefully give us this exact image. But here, we start with the biggest one. Like, okay, that's the biggest. That's going to be the, presumably, the celiac artery itself. So celiac artery, gives off three main branches: the left gastric, the splenic, and the common hepatic. And so you can think to yourself, well, we know the left gastric goes along the left curvature, and then up to the branches up to the esophagus. So this one is kind of staying central, medial, and then the splenic is going to go to the spleen. And just take a look at our organs. The left side of the body is over here, the spleen. So we're looking at this view right here. And so, okay, well, that makes this a splenic artery. And then we have the common hepatic, which must be on the other side. And then we know the common hepatic is going to give rise to the proper hepatic. And then that's going to give rise to our left and right hepatic. And then we have a branch off that is the gastroduodenal. And then the right gastric, which we know is going to eventually anastomose with our left gastric right here. And you can see that they are, in fact, kind of close to each other. All right, can you explain the organization of veins draining the stomach and their relationship to the hepatic portal system? So the basic idea is that all venous return from all organs associated with the GI tract goes into the liver via the hepatic portal vein. So that's this guy right here. After blood goes through the liver, it's going to go into the hepatic veins and go directly into the inferior vena cava. We know where that ends up, in the right atrium eventually of the heart. Okay, and so the hepatic portal vein is formed by a junction of the splenic vein and the superior mesenteric vein. So the splenic vein coming along here, going along the splenic artery, so it's behind the stomach right here. Then we have the superior mesenteric vein, right, superior to the mesentery. And then down here we have the inferior mesenteric vein, but the superior mesenteric and splenic vein are coming together and they form the hepatic portal vein. Overall, we can also see that we have other veins that are named according to their corresponding arteries. So we have the left gastro-omental, right, the left side of the body, gastro-omental, stomach, omentum. Then we have the short gastric veins coming up alongside the short gastric arteries. Okay, which was short gastric arteries came off of the splenic artery. Then we have the right and left gastric veins. So we have our left gastric vein here, our right gastric vein here, and just like with the arteries, the anastomose along the lesser curvature of the stomach, and they're draining into our hepatic portal vein as well. And then we have our right gastro-omental vein, and that will drain into our superior mesenteric vein. But eventually it goes back to the hepatic portal vein. Again, the idea is all venous return from all organs with the GI tract, associated with the GI tract, goes to the hepatic portal vein and through the liver. All right, and then note on lymph drainage. Lymph nodes follow arteries to the stomach and are named by their corresponding artery. All around the stomach, all lymph around the stomach drains into the celiac lymph nodes, and then those go into the thoracic duct, which we're very familiar with, falls along the spine. Overall. All right, can you describe the autonomic innervation of the stomach? So we have the enteric nervous system, which we know is associated with the GI tract overall, and we know that produces the slow wave, which gets our smooth muscle close to the action potential threshold. The enteric nervous system can provide low-level glandular secretions and help with peristalsis through slow wave production. Through those cardial cells that are between the longitudinal and smooth muscle layers, the longitudinal and circular muscle layers, the sympathetic and parasympathetic and sympathetic nervous system. For the parasympathetic, you have the vagus nerve via the anterior vagal trunk, which you can see right here, and that's going to innervate the stomach and increase glandular secretion, specifically hydrogen ion and pepsinogen from our parietal cells and chief cells, and then increase peristalsis, and then relax and dilate the pyloric sphincter, which are those down here. The sympathetic nervous system, you have the preganglionic nerves preganglionic fibers are coming from the greater splanchnic nerve right here, which is associated with T5 through T9. The postganglionic fibers are going to come from the celiac ganglia and plexus that are associated with this region, and as they travel to the rest of the stomach, this is going to work to decrease peristalsis, decrease glandular secretion, and then contract the pyloric sphincter, fight or flight. Parasympathetic is rest and digest. Okay, then we have pain signals. So pain stretch, usually greater splanchnic nerve from the sympathetic nervous system, and it's going to send signals to the dermatome layers. We said greater splanchnic is associated with T5 through T9, so dermatome layers of T5 through T9, and then the cell bodies associated with these sensory neurons is going to be the dorsal root ganglions of T5 through T9. Okay, so greater splanchnic nerve, you can see we have the left greater splanchnic and then the lesser greater splanchnic, and then all three of them together are going to give rise to the celiac ganglia or celiac plexus overall. All right, moving on. Clinical correlations. We talked about ulcers and the physiology material, but you have destruction of the mucus lining, and then the hydrochloric acid and the pepsin will erode and eat through the lining of the stomach. And specifically, if you have, so the posterior wall of the stomach rests on the body of the pancreas, and so if you have digestive erosion of this organ being a penetrating ulcer, it's a medical emergency and it's often fatal. Hiatus hernia is when our lower esophageal sphincter, you have a hernia near this region, and not good. And then gastric carcinoma is basically a mutated gastric mucosa epithelia and highly aggressive form of cancer. Current survival rate is only about 10% for 5 years. Okay, moving on to the liver, can you describe the position of the liver related to the 9 abdominal regions? So I think we said in this class we're going to use 4 divisions, so I don't know why they're saying 9 divisions here, but we'll roll the punches. So we have our 9 divisions, and you can see that the liver is posterior to the thoracic cage, and the diaphragm is deep to ribs 7 through 10, right? So 10, 9, 8, 7 right here. And then the inferior border is along the right costal margin, which you can see right here. And then the liver has 2 surfaces, the diaphragmatic surface of the liver, which is in contact with the diaphragm, and then the visceral surface, which is underneath. And we'll talk about both of those. In terms of the 9 abdominal regions, this is the right hypochondrium, and then the epigastric region that it's a part of. And then what would cause some abnormally large liver, hepatomegaly, viral infection, aka hepatitis B or C, viral infection, chronic alcohol usage, some autoimmune diseases, and then bile duct diseases where you have blockage of bile ducts can lead to an enlarged liver overall. All right, can you describe the superior surface of the liver? Well, we said the liver has 2 surfaces, and that's the diaphragmatic and the visceral surface. The diaphragmatic surface is exactly that. It's in contact with the diaphragm, and the superior surface, which you see right here, is part of the diaphragmatic surface, but it's not the only part because we have the posterior surface is also part of the diaphragmatic surface. So superior and posterior are part of the diaphragmatic surface. You can see that the superior diaphragmatic surface that we're looking at right now is divided by the falciform ligament into the right lobe and the left lobe, and then the liver is suspended by these ligaments, which we can see here, the anterior coronary ligament. And then you have the left triangular ligament and the right triangular ligament right there. And specifically, these ligaments are derived from a little bit of embryology, but the ventral mesogastrum. So mesentery, but you can see this here with the folding stomach. We have mesentery suspending our gut tube, and the ventral mesogastrum is going to eventually form our right triangular, left triangular ligament, and anterior coronary ligament. Okay, so can you describe the posterior and inferior surfaces of the liver? We sure can. So we're still dealing with diaphragmatic surface here. Inferior surface, not entirely, because we're going to start to get to visceral surface here. This bottom part is the visceral surface. But specifically, the posterior surface right here, you can look at it and you're like, well, that looks not so smooth. And that would be the bare area of the liver. And so the posterior surface of the diaphragmatic surface of the liver, this bare area is voided, has no peritoneal covering. And this is where the hepatic veins empty into the inferior vena cava. And it's formed from where the triangular ligaments and coronary ligaments meet the diaphragm. So basically, all of this area where we have the edge of the coronary ligament and the left and right triangular ligaments gives rise to the smooth, or this bare area on the liver, and there's no peritoneal covering there. Okay, and again, this is where the hepatic veins drain into the inferior vena cava, And we said that going back real quickly, the inferior vena cava, right, all of our blood in this region, that's venous, is returning and going through the hepatic portal vein, and then after it goes through the liver, it's going to go into the hepatic veins into the inferior vena cava. Okay, so not terrible. What recesses of the liver can you see in the adjacent sagittal drawing? All right, well, we have two recesses here. If only that meant a break from school, where we could go play games. Unfortunately not. It means two recesses such as the subphrenic recess and the hepatorenal recess, which is just a result of the liver attachment to the diaphragm via the coronary and triangular ligaments. So you can see the hepatorenal recesses right here. Why is it named that? Well, we have liver, the hepatum, and the kidney, the renal organ. And then you have the subphrenic recess right here. Why? This is the phrenic, aka diaphragm. Or diaphragm is right here. All right, can you name the structures that form the letter H on the ventral surface of the liver? aka, we're finally on the visceral surface. Exciting. All right, so the ventral surface of the liver, it is divided into four lobes: the right visceral lobe, the caudate lobe, the quadrate lobe, and you can see that we have a vertical division here. All three of these lobes right here correspond to the right lobe of the diaphragmatic surface, which is this guy right here. So we're talking about this area. And then we have a fourth lobe, which is the left visceral lobe, which corresponds to just the left lobe of the liver on the diaphragmatic surface. All right, so this is right lobe of the diaphragmatic surface, this is the left lobe of the diaphragmatic surface, this is the right quadrate and caudate lobes of the liver, and we divide it into these four based on the structures that we have here, which form kind of this nice H shape. Specifically, this vertical leg of the H is formed by the ligamentum teres, is continuous with the falciform ligament, right, and that forms the right and left boundaries on the diaphragmatic surface. And then that comes from a bladed umbilical vein that forms this eventually. And then we have the other vertical leg of this H is the gallbladder and the cystic duct, which drains into our common bile duct, and the inferior vena cava. And then horizontally, we have the portal triad, aka the porta hepatis, which is the hepatic duct, the proper hepatic artery, which splits into our left and right hepatic arteries, and then our portal vein, which knows that enormous vein that everything is going through to get to the all the venous blood in this region is draining into the portal vein to go into the liver. All right, then we have our inferior vena cava here, which we can see is contributing to the leg of the H. All right, what structures enter or leave at the porta hepatis, aka the portal triad? We have the hepatic duct, proper hepatic artery, and portal veins. Very good. Okay, what structures divide the liver into functional lobes, and why are they clinically relevant? All right, so we had lobes based on the surfaces. We had the visceral surface, right, caudate, quadrate, left, and then on the diaphragmatic surface, we had the right lobe, left lobe, and then now we have functional lobes. Okay, so it turns out there's 8 functional lobes, and these 8 functional lobes are determined by triads, and you can see all these nice triads here. And so what are these? These are arterial, portal vein, and hepatic duct, the triads, or branches of these things. And then venous drainage from the liver, aka hepatic veins, are not part of the portal triad. So arterial, portal veins, and hepatic duct. And then you can see that makes up 8 overall functional lobes. And then blood supply to the liver. So we've talked about the portal vein, right? All of the venous blood flow from this region is going through the portal vein, but it's important to note it is kind of a medium O2 content. It's not like perfectly as high as regular arterial blood, but because it's passed through the intestines, or passed by the intestines, but it is very rich in nutrient from the small intestines, and then compared to the inferior vena cava, it does have a higher O2 content, which is what we're trying to say here. All right, then we have the proper hepatic artery, which is going to split into the left and right hepatic arteries, and it brings very rich oxygen-rich blood to the liver, and it is a branch of the common hepatic artery. All right, which we know is coming off of our celiac trunk. So our common hepatic artery from the celiac trunk gives us our proper hepatic. Our proper hepatic gives us our left and right hepatic arteries, and that's going to each of our 8 lobes, which you can see are nice triads right here. So hepatic artery, then we have portal vein, and then hepatic duct going to each of our 3 lobes. And we have our main portal triad right here. So the main triad with the portal vein, proper hepatic, and hepatic duct overall. All right, so proper hepatic, this is our main triad, our bile duct, our hepatic duct, and the hepatic duct drains into our common bile duct. Okay, so not terrible. Do we need to know all of the names of each of these? I sure hope not. So we'll just continue from there, but take a look at this diagram if you want. It's just labeled by anterior medial, right anterior lateral, anterior medial. There should be 8 overall. All right, where can you find the hepatic veins that drain to the inferior vena cava? All right, well, it's our friends, the diaphragmatic surface. So I should fix this, but the diaphragmatic surface is where we'll find it, in particular right here, which is our bare area. And we have the hepatic veins are draining into our inferior vena cava, and then once again, blood flow is going into the liver from our portal veins, with all those nutrients and straying from all the other organs in this area, and then it leaves via the hepatic veins into the inferior vena cava. All right, we're almost done. Liver clinical correlations. A rupture of liver results in intraperitoneal bleeding, potentially fatal. That is not good. A major site of metastatic carcinoma, which is cancer of the epithelial tissue. Cirrhosis of the liver has a buildup of connective tissue and caused by alcohol or drug use and destruction of hepatocytes, so liver cells, and leads to liver failure, not good. Hepatitis is a viral infection, inflammation of the liver. Jaundice, which we should probably familiar with, an elevated level of bile pigment found in the bloodstream, and causes a yellow appearance of the skin and conjunctive eyes. One of the possible causes for the pathology is the blockage of the bile duct system by a gallstone, and this blockage causes bile to back up in the liver and prevents further processing of the bile pigment, aka bilirubin, from the blood. And so if you can't process more bilirubin in the liver due to blockage of the bile duct system, then you're going to have excess bile pigment in the blood, and this is going to cause your skin and eyes to appear yellow. All right, and then liver regeneration, it's the only visceral organ capable of regeneration. That's pretty cool. Okay, so can you describe the portal system and the various clinical signs of portal hypertension? Well, this is just a nice diagram. It's showing what we've already said, which is all venous drainage from the GI tract goes through the portal system, and you can see all of these lovely veins from all of these organs coming into our hepatic or portal vein, and we have basically what would cause portal hypertension in this set of veins. Number of things. We're very familiar with thrombolism, blood clots, liver cirrhosis, disease, scarring, which would result in scarring that causes obstruction of blood flow. And then for the rest of the world, the U.S., you typically see this cirrhosis of the liver due to maybe drinking too much. And then the rest of the world, you have a parasitic disease, which is more often causing this, hypertension, schleistosomiasis, it's a parasitic disease. In terms of symptoms, blood in the vomits, blood in the poop, bloated stomach with rapid weight gain due to basically leakage of fluid from these veins into the abdominal cavity, edema in the lower legs, confusion, disorientation, those are the main 5, and then ascites, which is fluid in the abdominal cavity, and then an enlarged spleen are also evidence of portal hypertension. We were told one specifically in lecture, which was the caput, aka head, medusa, and so these veins that are, you have your thoracoepigastric tributaries, right, and then those are anastomosing with your paraumbilical veins, and those drain into the portal vein overall. And if you have portal hypertension, then you are not getting blood through the portal system, and so you have enormous distension of the superficial veins to bypass the system and drain directly into the inferior vena cava instead of going through the portal vein and then through the hepatic veins on the other side of the liver. Okay, but why would you have poop, blood in the vomit? Well, think about getting portal hypertension. You get blood going into the esophageal veins, blood in your poop. Well, you have your rectum down here, so hypertension might be causing blood to go into your rectum, and then bloated stomach with rapid weight gain, fluid going into your stomach, fluid going into your abdominal cavity from hypertension overall. Okay, can you describe the bile duct system? We're almost done. Does your cadaver have a gallbladder? I know ours did. The gallbladder, which we can see right here, is a smooth muscular sac responsible for the storage and concentration of bile. It can contract, as it has a smooth muscle, and inject bile through the cystic duct, which we can see here in the spiral valve. The spiral valve is a valve name only, it's just the shape of a spiral in the cystic duct, and it travels with that hepatodual ligament anterior to the portal vein and lateral to the proper hepatic artery. The cystic duct drains into the common bile duct. You have your right and left hepatic ducts. Come from your common hepatic duct, which drains into your common bile duct. Those go down to the bile duct sphincter, which often is closed. And then when you eat, it will open up and mix with the enzymes from your pancreas. But you have another duct right here, or another sphincter right here, which is the sphincter of the hepatopancreatic ampulla right here. And you'll have mixing of the pancreatic enzymes and enzymes from, and your biles from the gallbladder. All right, but the anatomy of the gallbladder, you have the fundus here at the bottom, you have the body, and then you have the neck, which is connected to the cystic duct overall. All right, good job. Moving on, almost done. Blood supply to the gallbladder. It's supplied by the cystic artery, which is coming off the right hepatic artery, which comes from the common, or the proper hepatic artery, which comes from the common hepatic artery, which comes from the celiac trunk, which comes from the descending aorta. And so you can see that here. Celiac trunk goes to one of its 3 branches is the common hepatic. Then you have the hepatic, the proper hepatic, which splits into our left hepatic and then right hepatic. And the right hepatic is going to continue to the liver, but you also have a branch of that is going to give the cystic artery, and that goes to our gallbladder. And then, importantly, the cystic artery is within the hepatoduodenal ligament, and it is within a region of surgical significance called the cystohepatic triangle. So the cystohepatic triangle is right here. Let's see if I can use better color. Right, so that's the cystohepatic triangle, and its boundaries are formed by the common hepatic duct right here, medially the cystic duct, which we know is what is connecting to the gallbladder, and then superiorly is the liver itself, but the contents are the cystic artery going to the gallbladder, and then the right hepatic artery, so the right hepatic artery, which we see right here. Okay, so that's just about it. Does your cadaver have gallstones? They might. We can see this gallbladder is full of gallstones, and you can use ultrasound to find them. But that's it. The end. Good job, guys, and good luck studying. As we said at the beginning, you've taken so many exams. You're fully capable of doing this. Treat it like a game. How well can you do with what you know, and you're gonna do awesome. Okay, bye, guys.